Hi, and welcome to the Future of Dermatology Podcast. I'm your host, Dr. Faranak Kamangar, board-certified dermatologist. We are here to talk about anything and everything dermatology related. You'll hear from me and my guests who are dermatologists, physicians, experts, scientists, residents, and medical students in the field of dermatology. We publish weekly, so if you like what you hear, hit that subscribe button and show us some love, and thank you for joining us.
Hi, welcome back. Today we are going over a presentation that we gave at one of our SF Derm conferences and also at our Cal Derm conference last year on acne topicals. Acne, of course, is the number one most common skin condition that we see in the US. Dermatologists treat it all the time, and we know the level of psychological distress that it has on our patients. We know our teenage patients that come in and they are looking down and they just feel terrible about their acne, and you can just tell it's really affecting them. We have lots of studies showing quality of life metrics, but we can see it every day in clinic. And then when we clear their acne, they come in just completely different people. Their inner self comes out, they have confidence. And as dermatologists, we just intimately know how important it is to get to acne, treat it early and treat it well. So it's just not affecting our patients' everyday lives. But how can we treat it a little bit better, and how can we treat it faster? So let's take a look at our topical therapies. And our AAD guidelines came out this year. They're updated, and they do have certain ones that are preferred over others. So we'll take a quick look at these. The AAD guidelines, the group looked at multiple, various studies, and they came out with 18 evidence-based recommendations and 5 good practice statements for the treatment of acne. They strongly still recommend benzoyl peroxide. That's one of our workhorse topical ingredients, topical retinoids, and then topical antibiotics. Of course, we're talking about antibiotic or topicals here, but there's also oral doxycycline and oral isotretinoin that we know works really well. Conditional statements were given to clascoterone, salicylic acid, azelaic acid, topically. And then out of the orals, conditional recommendations were given to oral minocycline, sarecycline, oral contraceptive pills, and spironolactone. Good practice statement, the main one, to combine your topical therapies with multiple mechanisms and to try to not give just one. Although we know in clinic, sometimes for patients' skin is a little bit irritated or can't handle it, might be hard to do multiple topicals, but when possible, combining will work better. Other good practice statements in the guidelines were to limit systemic antibiotic use and combine systemic antibiotics with topical therapies, because we know that eventually we want to stop systemic antibiotics and we would like a topical therapy as a background for the patient to rely on when they're off of their treatments. And then intralesional steroids are still good for larger lesions. The acne grading system that's used in a lot of our clinical trials is the Investigator Global Assessment, or the IGA. Many of our studies, when they get FDA approval, they need to give a percentage of patients that get clear, which is grade 0, or almost clear, which is grade 1. This is actually kind of hard to do. A lot of patients that get to even grade 2, mild severity, they still look pretty good. Maybe their acne's gotten better, but for these protocols, they're pretty stringent. Benzoyl peroxide, just going to talk about benzoyl peroxide briefly. It just works really well. It's highly effective, and it's a very equitable ingredient because you can get it even over the counter without going and seeing a dermatologist. You can get 2.5% to higher levels of benzoyl peroxide, and it works really, really well. So it's still strongly recommended. There was a bit of controversy with benzoyl peroxide earlier this year with a report that Valagure put out to the FDA. But looking at the data, benzoyl peroxide is still a very safe ingredient. So I wouldn't be worried about prescribing it. What they did in their studies is that they put benzoyl peroxide in really hot weather, like sub-Saharan Africa desert type of weather, for 18 days. And then they saw that there was some conversion to benzene, which could potentially be carcinogenic, but in real life, that's really hard to happen. But I think it's just another thing for manufacturers to make sure that these ingredients are stabilized and they are combined with antioxidants for stabilization. But benzoyl peroxide is still a mainstay. Then there's, of course, our topical retinoids, tretinoin, adapalene, tazarotene, and trifarotene, and our topical antibiotics, clindamycin, erythromycin, minocycline, and dapsone. This is a chart that compares the IGA 0 and 1 at 12 weeks that come from the package inserts of these topical therapies. It's important to know that on this chart, I don't have the placebo group. And although these percentages look good, a lot of the times the placebo group actually looks pretty good too. But just a comparator so we can kind of compare our topicals. And looking at our topicals, they're not super effective. I think that's one of the main trends that we'll see. For psoriasis, eczema, we have such good therapies and we're going for like PASI 100 and getting patients 100% clear. Acne has not necessarily followed that trend, but our treatments are getting better and better. For example, adapalene gel that you can get over the counter, at 12 weeks, 16% of our patients can achieve IGA 0 or 1, meaning clear or almost clear. Let's move up the ladder a little bit, going to like maybe tretinoin 0.05, about 18%. So adapalene gel, tretinoin, pretty comparable there. Tazarotene, about 19%. Adapalene gel, 0.3% goes to 21% versus 16%. So maybe a mild improvement, but pretty much same ballpark. And also these are with, in theory, strict adherence, which we know it's hard for many of our patients to do these treatments every single day. Compliance is an issue. When you do combine, you get better results. So clindamycin and benzoyl peroxide, which is kind of an OG combination a lot of our patients get, that's about 29%. So you do have a jump in efficacy. Tazarotene foam actually works pretty well, 29% on its own. Dapsone gel, 7.5% is 30%. Dapsone gel, 5% is actually 38%, seems higher, but that was twice daily. It was just the way their studies were set up. So Dapsone is a good additional too. And then they're getting better and better. So the newest kind of combination cream that came out is combining clindamycin, adapalene, benzoyl peroxide, and it got to 49%, which is pretty good. But the main problem is some of these newer medicines, they're really hard to actually get covered and get patients to be able to pay for them and obtain them. And the main thing is a lot of the treatments that we have, there's different things, mechanisms causing acne. Of course, one of the main contributors is sebum or sebocytes or sebum production, which the majority, actually all of our topicals that I have in the purple on the left side, they actually don't reduce your sebum content. They do target inflammation and normalize keratinization of skin, which are components of acne, but they don't really target sebum. When you're talking about what actually reduces sebum, you're on the other side, clascoterone cream, because of its anti-androgen properties, can reduce sebum. And of course, isotretinoin is our also an OG treatment. It works so well because it does target inflammation. It does target keratinization similar to the other topicals, but what it does that's different is it has sebostatic and sebum apoptotic effects. And that is why isotretinoin works so well. So after therapy, isotretinoin can get about 87% of people clear or almost clear. It's important to note that's not at 12 weeks. It's however long it takes them to finish isotretinoin, usually 5-6 months, but could be longer. The other thing I'd like to talk about is the 1726 nanometer laser. This is not talked about much, and it wasn't in the acne guidelines, but this is a laser that also with selective photothermolysis can cause sebum reduction and sebaceous gland apoptosis. That's a really unique mechanism of action that we should start talking about more. And patients after finishing treatment at about a year follow-up, about 66% achieved long-term clearance. Those are pretty good numbers to look at. One major barrier, of course, is that this is still on the cosmetic side. There is this arbitrary divide of what insurance will pay for that will kind of put our treatments in these very arbitrary categories. But if we take that out of our mind and are just looking at things that work well, that works pretty well too. So I think when we're talking about outside treatments, that is one we should start thinking about. Just another slide showing the different mechanisms of acne and the importance of androgen inhibition. So, of course, we can also think about our oral contraceptives, spironolactone, topical clascoterone. If you block androgens, you're also going to block that androgen cause of sebum increase. So, androgen inhibition will modulate sebum. Of course, you have to usually stay on those treatments, whereas the isotretinoin or the 1726 nanometer laser, they're causing sebaceous gland apoptosis. So once you take that treatment away, you have long-standing improvement. But if you take away the androgen inhibition, usually the sebum comes back again. This is just a slide also showing the 1726 nanometer wavelength. This is interesting science, and one we should start looking at, because there are people that just really don't want to do isotretinoin. So when those conversations are had, if there's hesitance to do isotretinoin, this should maybe be considered to bring up as an option. And lastly, I do want to talk about, we don't usually give a lot of credit to things like azelaic acid, salicylic acid, sodium sulfacetamide, glycolic acid, mandelic acid, TCA, but these are topicals that are effective as well and largely out there over the market in all sorts of combinations. And when you look up social media and you look at dermatologists talking about these topics, it's super popular. These posts get millions of views, meaning even though we may not bring it up as first line, our patients are really interested in these therapies. So many times I do, even earlier on, start bringing up things like azelaic acid or glycolic acid, sodium sulfacetamide as well. So sodium sulfacetamide is actually amazing for inflammatory acne lesions. It decreases it quite a bit. Also, separately works for acne rosacea as well. So just to not forget about these additions, and a lot of over-the-counter formulations are nice enough that sometimes patients might prefer it better. And really in the game of treating acne, compliance is ultimately the most important. Thank you.
Thank you for listening to the Future of Dermatology podcast. Remember to hit that subscribe button and share the podcast with your friends. The more you share and subscribe, the more we'll be able to grow and share our dermatology knowledge. If you have burning dermatology questions, feel free to leave them in the comment below, and we would love to address them in a future episode. And please note that this podcast is not intended to substitute for medical advice from your doctor.